Welcome, everyone, to the People's Health Briefing, a key component of our Trusted Voices campaign. I'm Dr. Noha Malata from Roots Community Health, reporting for the week of June 3rd, 2024. As health professionals rooted in Oakland, serving some of the most vulnerable populations in the Bay Area, we are here to cut through the noise and bring you the latest information on health issues relevant to us all. The goal of the People's Health Briefing is to equip you with the best knowledge and insights to keep you, your loved ones, and your community as safe as possible. This week, after an update on COVID and H5N1, I will talk a bit about COVID and travel. Taking a look at wastewater nationally, we can see that it is considered low, and that probably sounds good in the grand scheme of things, but actually last time I reported it was minimal, and minimal is less than low. So it is increasing, and we can see here the slight upslope. And of course, we've been here many times before, so no particular surprises. We know it's not really a matter of if it's going to go up, but when. Here we can see it broken down by region, and we can see that the Western region, which is in that darker teal color, was the lowest, but in early May, it started heading up and has now crossed over all the other regions, and now it is the highest of all regions. Last summer in the Western region, we seem to have hit our low point in mid-June before things started to head back up again. So if we are indeed at that point where things have hit their lowest point, that was in early May. And if they're heading up now, that would be a little earlier than the low point we had last year. So about 6 weeks earlier compared to last year. So we are kind of still looking for a pattern of some sort, and give or take a month or two, I think we can at least say that our highest points seem to happen sometime in winter. We seem to have a low point sometime in spring, and we usually have our second highest point at some time in the summer. It's happened in every month. And SARS-CoV-2 circulates and causes disease all year round. So far, that's what we've got. It's not exactly the seasonal pattern we might like to see, but that's what we've got so far. And taking a look now at hospital reporting through the National Healthcare Safety Network, hospital reporting on what's going on with COVID became voluntary on May 1st. Since that time, we've gone from over 90% of hospitals reporting to now about 38% of them reporting. And it is quite variable state to state. For example, 99% of hospitals in the state of Washington are continuing to report, while only 2% of hospitals in West Virginia are reporting. Everywhere else roughly seems to be pretty much in the middle somewhere. So since this is really in flux, and mostly plummeting, actually, I'm not going to do anything with this just yet. Once things settle down and we're able to see which states are reliably and consistently reporting, maybe those become kind of bellwether states that we can look at for their trends. Either that, or we have to decide that we can no longer really rely on this metric for anything, and we'll just have to do what we can without it. So more to come on this. And taking a look at death, the week ending May 4th, there were 378 deaths in the United States from COVID. This represents the fourth week in a row where we have under 500 deaths in a week. So that is better. It's certainly hopeful to see it continuing to go in this direction, hoping this will sustain, even given what we've just said about SARS-CoV-2 circulating year round and cases coming back up at some point. We'd really like to see not so many deaths every week. We'd love to see them come down to zero at least sometime during the year, like we see with flu and RSV, where we have long periods of time actually without flu or RSV deaths. We have not seen that at all since the onset of the pandemic with SARS-CoV-2. So we got room for improvement here. We need to be doing better. This is just too many deaths every single week from a pathogen that is spread by the respiratory route. And like I say, flu and RSV are a small fraction of this, even at the height of flu and RSV season, let alone taking a look year round. So we should be doing what we can to decrease transmission of SARS-CoV-2, make sure that those who are vulnerable stay up to date on their vaccination, and those at risk of a poor outcome get timely treatment. And now to report on some long COVID data, because unlike some of our acute COVID data, it does appear that the long COVID data collection continues. And I've talked about this a little before, and I am going to go into more detail on this next week when I talk more about updates on long COVID. But I'm just going to show a few highlights here from the long COVID household pulse survey dashboard. And first off is the percentage of adults in the United States who have ever experienced long COVID. And that is up close to 18%. So, of course, for the most part, we expect this number to continue to increase because it's about people who've ever had long COVID, and even if that long COVID has since resolved or improved. So, this is really about giving us a sense of the percentage of all adults who ever have experienced long COVID. And I think it's significant to be almost 18% because this means that even if the person is feeling better today, they had prolonged symptoms after their acute case of COVID at some point in time. And we're only 4 years into this, and people can get COVID, obviously, repeatedly. So this is something worth paying attention to. Now, this is showing the percentage of all adults currently experiencing long COVID. And this one is looking at the percentage of those who have long COVID currently out of all adults who ever had COVID. So this to me is concerning that 9% of people who have had COVID are currently experiencing long COVID. And this is a very significant percentage of people in the United States currently experiencing long COVID out of all the people who've ever had COVID. And they do have this broken up by a lot of different characteristics like demographics and geography and other things. So if you're interested, the link is in the post. You can kind of take a look at different aspects of this. But again, I will be looking into this in more detail next week. Lastly, for today on this topic, I'll just show that this is the percentage of all adults currently experiencing long COVID, period. So this is out of all adults, not just those who've had acute COVID. And I find this pretty troubling that over 5% of the entire US adult population is currently experiencing long COVID. So once again, having this high number of people currently experiencing long COVID it's concerning for keeping an eye on the burden to our overall society. It's important in terms of assessing our own individual risk because it's not just about a bad outcome from acute COVID, it's also about these long-term impacts. And it's also something that we need to really gain a better understanding of, not only for finding solutions for these individuals, but also so that we can understand the burden of this condition on our entire society. So the impacts that it may have, like on caregivers of people experiencing long COVID, of children, if these individuals are parents, on coworkers and colleagues, and on the workforce in general. And remember, this is just looking at adults. This is not even assessing children, which we know long COVID happens in children, and we'll talk about that more next week. But this is definitely concerning, and this is certainly part of our reality now. Now taking a look at variants, KP.2 variant continues to be on the rise. It's projected at almost 29% of variants. Remember, KP.2 has some unique mutations. They're being called the flirt mutations. And we should be finding out this week whether the new 24-25 COVID vaccine is going to target variants with the flirt mutations or not. In case you're interested in listening to the deliberations of the FDA's VRBPAC committee, that's the Vaccines and Related Biological Products Advisory Committee, they're going to be the ones making these recommendations. It's a full-day meeting on June 5th from 8:30 to 4:30 Eastern Time, and we'll certainly report back next week on their recommendations. And just as we're about to head into that time frame of where the 24-25 vaccine will be recommended and distributed for the fall, the federal government decided to end the free COVID vaccine program for uninsured and underinsured individuals. So this was called the Bridge Access Program. through which many of us were able to obtain vaccinations for uninsured and underinsured individuals. And more than 1.4 million free vaccines have been administered since the launch of this program in September 2023. So the Bridge Access Program was not supposed to end until December 2024, but the funding has been cut, so it's going to end in August. So it will not be part of the fall vaccine rollout. So this timing is definitely challenging because this does not probably leave enough time for any backup arrangements to be made. And those backup arrangements, for example, possibly there will be a vaccines for adults program. That would be great. This is actually in President Biden's 2025 budget request. We have vaccines for children, a vaccines for children program. It's wonderful. It makes it so that all children, irrespective of their income level or access, all children have access to vaccines in the United States. It is a very successful program, and we're really hopeful that vaccines for adults will become a reality. But even if it is, we're looking at 2025. So once again, not in time for the 2024 fall vaccine rollout. The other possibility that we sometimes see are that the manufacturers could implement what's called a patient assistance program. So that may be something to look at as well. So we will be keeping an eye out for those, because in all likelihood, our local public health departments will not have much, if any, free vaccine, simply because anything they have right now is going to be expired or deauthorized once the 24-25 vaccines are available, assuming that the new formula is a new formula, which I believe and hope it will be. So therefore, what we have right now will no longer be authorized. So looks like no more free vaccines for uninsured or underinsured coming up for this fall campaign. Now, here in California, we are quite fortunate that we basically now have full coverage for all low-income people, including undocumented individuals. I wanted to quickly run through this because it's important information. If you live in California, you work with folks in California, this is a pretty big deal. Everyone, regardless of their immigration status, if they're eligible by virtue of their income, can be now covered by Medi-Cal. So just a quick timeline: in 2010, the Affordable Care Act was enacted into law. Not all states expanded Medi-Cal, shockingly. Still to this day, we have a small handful who've chosen not to accept any federal funding in order to provide coverage for people living in poverty. That is certainly a shame. In California in 2015, all children under 19 became eligible for Medi-Cal. This is a big deal. There are other states that have kind of universal coverage for children. So this is important to know in your state. Are all children covered? But in California, they have been since 2015. Then in 2019, this expanded up to age 25. And then in 2022, something I covered on the People's Health Briefing at that time is that all income eligible undocumented people 50 years and older became eligible for Medi-Cal. So that just left one last age group, 25 to 49. And as of this past January 1st, 2024, everyone at 26 to 49 years old is now eligible for Medi-Cal, as long as they meet those income requirements. So this coverage is basically available. And so at least in theory, everyone in the state of California should be able to get their COVID vaccines, among other things, through Medi-Cal if they meet those income requirements, or through their own insurance if they have insurance, and everyone else would need to pay out of pocket. And I think it's important to underscore that California is unique in terms of covering so many of its residents. And in many states, this just simply is not the case. And as we know, SARS-CoV-2 doesn't really care about any kind of geographic borders. So we can expect to see situations of uneven coverage just based upon access, which is really a sad thing to be reporting right now, because we actually got a rare glimpse of what it would look like to have universal access to something in healthcare in this country. And it was pretty great. Healthcare providers didn't have to worry about checking on insurance, the insurance that you had. It didn't matter how much money you made, you could access something that helps prevent you from going to the hospital or dying or passing it on to everyone else. And when it comes to things that are highly contagious, this seems helpful and important. And so now we just hear these platitudes about having tools, but these tools are not accessible to everyone. So I think this is a really excellent example of how our systems create and maintain disparities. If certain groups of people who are already marginalized get further marginalized because they can't access basic preventive health interventions, then the likelihood that they will suffer bad outcomes is increased. So it's really pretty simple, and it's pretty sad to watch it unfold in real time. Briefly, we've seen the headlines in the news that Dr. Fauci was called to testify publicly. This is for the first time he's had to do this since he tried to retire at the end of 2022, retired from his position as director of the National Institutes of Allergy and Infectious Disease. So I have yet to listen to the testimony. Sounds like it covered a range of topics, some surely more relevant than others. After I listen, I'll be sure to report back anything of significance that came up. And definitely, listeners, if there's any topics that were raised during those hearings that you think are worth exploring, please feel free to send them to us by direct message or leave a comment or email us at admin@rootscommunityhealth.org. Now, briefly, to provide an update on H5N1, the CDC has reported a third case of H5N1 in humans tied to the U.S. dairy cow outbreak. What's unique about this third case is that, unlike the first two, this one is causing respiratory symptoms. So, according to the CDC report, the patient was given antivirals and is recovering at home. But we still really don't like that this case caused respiratory symptoms for a couple reasons. First, we don't really like any progression in these evolving situations. We'd rather things get milder or go away. But the first two cases basically caused only eye infections. And now this third one is causing respiratory symptoms. And none of these cases are related to each other, which suggests that this is probably more widespread than we know because they're just kind of happening at the same time independently in different places. And it's really unclear how much testing is really going on, but we know that it is not enough, obviously, to catch all of the cases. But the second thing we might be concerned about is that if it's causing respiratory symptoms, does that mean it's more likely to be able to be spread in a respiratory fashion? We don't know that yet, but we really don't want that. So we need more information. So right now, no need for any additional alarm at this stage, but we definitely want to hear more. What we want to know is more about the genetic sequencing of the strains that cause this illness. Is it any different than the ones that caused the prior illnesses? Has it mutated in any way that we need to be concerned about? And significantly, can we learn more about transmission? If it has mutated, does that have any implications as far as how it's being spread? So more to learn here, but so far they're saying that no one else in this person's household has gotten sick, so that's good news. They were offered antivirals as well. They haven't disclosed much more information than that. And again, we don't really know how much testing is going on, how much more widespread this may be. So we'll continue to keep an eye on this and report more as we have it. In the meantime, the main things to do are really pretty simple. This should not be hard. Don't consume raw milk or products made from raw milk. Products made from raw milk are pretty commonly out there. So just take a look at what you're purchasing and consuming and try to avoid raw milk products. Don't touch wild birds. Don't touch any dead animals, please. Cook your meats thoroughly. And if you work closely with animals, monitor guidance from any of your relevant regulators or from your industry. This is not an exhaustive list here, but just an example. And now I want to take a moment to review this study that was just published May 21st, 2024 in the International Journal of Environmental Research and Public Health. and it is entitled The Risk of Aircraft-Acquired SARS-CoV-2 Transmission During Commercial Flights, a Systematic Review. And as we head into summer break, many people will be traveling, so I thought this would be a good time to review this material. So this is a systematic review. They ended up doing a detailed review of 15 research articles. So remember, with the systematic review, they're going to have criteria, they're going to cast a wide net, they're going to eliminate a bunch of different articles, and they did that, and they ended up with 15 articles describing 50 flights, and they used individual flights as the unit of analysis, and they were able to do quantitative and qualitative analysis. So both looking at the numbers and also looking at some of the other things that were being described in the studies. The articles were all published before vaccine availability, so from January 2020 to April of 2021. And looking at this time period turns out to have some advantages in terms of our overall understanding of the transmission. And one of those is that so much more information was being collected at that time. So out of the studies they looked at, the risk of bias was really low. So what do I mean by that? When we say bias in research, we are talking about the likelihood that something in a study's design or its methods or how it was carried out could give misleading results or conclusions. And so in this case, they were basically able to just include cases that had actual sequencing of SARS-CoV-2 virus that literally allowed them to completely trace, like conclusively trace, essentially transmission back to the index case on the flight. So though that's amazing, and we're not doing that anymore, which is sad. So it makes it harder to do a study like this without a lot of bias. But this makes it pretty conclusive or very low risk of bias. So they included those. And then they also also included what they called moderately low risk of bias. And that is where they didn't have the genetic sequencing, but they did have contact tracing, patient interviews, and a PCR confirmation of infection. So we really don't have any of those things very much anymore. And so it makes it harder to do these kind of studies without bias. But for this particular study, the ones they were able to include had either very low or moderately low risk of bias. So that is very important. So these are good quality. And when you put them all together, you take them all together, it makes that evidence that much stronger. So what did they find? One of the main findings was that the duration of the flights predicted the incidence of cases when masks were not enforced. So if you compared a short flight without masking, and a short flight was considered less than 3 hours, and you compare that to a medium flight, which is considered 3 to 6 hours, and these are both without masking, then there was a 4.7 times higher incidence of COVID cases on the medium flights compared to the short flights. So when you didn't enforce masking, the duration made a big difference. 4.7 times higher incidences of COVID cases compared to the short flights. And then when they took a look at the long flights, which was over 6 hours, and again, this was without enforced masking, it was associated with 26 times increase in incidence of COVID cases. So that's very significant. So 26 times more likely to have an incidence of COVID cases on long haul flights. And what they basically were able to calculate is that for every 1 hour longer that the flight was, there was a 1.5 times increase in the incidence rate of COVID cases. So longer flight, greater risk. And this is, again, without masking being enforced, which, of course, masks are no longer enforced. But a second really important finding was specifically about masking. So even on the long flights, the ones with enforced masking had no transmissions reported. So all 6 long-haul flights where masks were enforced had 0 transmission. This is pretty amazing. It's actually very striking. So surprise, surprise, not a surprise to a lot of us, masks work, even on long haul flights where the risk of transmission is high, 26 times higher than the short flight when there's no enforcement of masking. So this tells us that this is an inherently higher risk setting But when masks were enforced, there was no transmission on all 6 of these flights. And what they stated in their discussion is our findings suggest that aircraft acquired transmission is not inevitable if masking is strictly enforced. So, of course, we know that those days are over, and masking it's not only not enforced in any way, shape, or form, but sadly, it's not even suggested or spoken of or recommended at all, which I find completely ridiculous. There's all sorts of safety measures on planes about your overhead bags and your tray tables and all these other things, and we can't even say masks would reduce your risk of getting sick when the evidence clearly tells us that it does. So we just have to inform ourselves and do what we can ourselves. Another interesting, somewhat disturbing finding from the more informal analysis they did was that how close you sat to the index case was not the best predictor of whether you caught COVID. So passengers seated many rows away from another person, a person who had COVID, in several instances actually caught it from a positive person who was 5, 6, or 7 rows away. So they weren't able to surface why this happened exactly, but of course we know people walk around on the plane, boarding and deplaning. People are passing each other, people use the restroom, the direction of the airflow on the airplane likely also plays a role in this. So I think the bottom line here is people who had longer flights had a higher incidence rate than shorter flights when masking was not enforced. Wearing a mask during your flight reduces your risk of contracting COVID-19 on the plane. And who wants to contract COVID-19 on a plane? I mean, especially if you're going to go visit loved ones or if you're going on vacation, who wants to be sick? And the risk here is pretty plain if you're not wearing a mask. And also, I hope this is also sending a message to airlines, that you need to be continuing to assess and look at your air quality and how it can be improved and how we can improve safety overall on airplanes, because it would help for the current pandemic situation, but also in the event of another pandemic, we really need to be ready to implement better technology as well as better policies, like maybe spacing people out like we did in the earlier days of the pandemic. So even though it seems that despite what the data is clearly telling us, there is no collective will to enforce greater safety on flights. And the reasons why were pretty well outlined in the introduction of this article. If you're interested, it's linked in the post. But basically, that the airline industry lost about $370 billion in the first year of the pandemic. And trying to do anything to restrict that industry is just costing some people too much money. So, but nonetheless, the evidence is the evidence. So it really is a word to the wise and a reminder to us all: masks work. Airplanes are important sources of transmission of respiratory pathogens. They really meet all the criteria for high-risk environments. They're small, they're enclosed, they're densely populated. And regardless of what the airlines might claim about how great their filters are and how great their airflow is, the fact is they are enclosed vessels where aerosol particles are well mixed. There's a high density of occupants, and you may be in there for a long period of time in that enclosed space. This is all a recipe for transmission. We know this. There's no magic about being in a plane that is going to provide any sort of force field to protect this. This study strongly suggests that mask wearing is a very important intervention to reduce transmission. Of course, what it also told us is that two-way masking is the real way to prevent transmission. But since that is no longer a reality, one-way masking is going to be the next best thing if you're going to fly. Also, you may want to consider skipping the meal so you can remain masked. There was a lot of talk about the meal time, especially on longer flights. If that is not possible, you may consider eating at a different time than everyone else, because we know that eating is one of those times when aerosols and droplets do get expelled. at a higher rate than just regular breathing. So if you're going to be traveling, travel safely. Don't let COVID be your wingman. And let's remember all of our best practices to avoid contracting and spreading COVID. This includes getting vaccinated. This includes wearing a high quality filtration mask, gather outdoors whenever possible. It's almost always safer than indoors. Pay attention to ventilation and filtration in your indoor areas, and strategic use of testing and isolation if you are positive. Remember, there are outpatient treatments for SARS-CoV-2, but time is of the essence. If you test positive, you should have a plan ahead of time. If you test positive, you really need to get that prescription and started the sooner the better. And you'll need to do this with your primary care provider. We see that all of the free things out there are starting to go away. So just make sure you still know how to access whatever it is that you need, vaccines, treatments, and so on. If you don't have a primary care provider, please get one. Don't wait until you need one to try to find one. Establish a relationship, get your blood pressure checked, your baseline labs checked, like cholesterol, sugar, hemoglobin A1C. Get your appropriate cancer screenings for your age and risk factors. Know where you stand. And remember to eat a balanced diet, incorporate fresh foods, avoid sugary drinks and processed foods, get some regular physical activity. Unless you don't feel well in that case, please get your rest. Manage those stress levels and get a good night's sleep. This concludes today's People's Health Briefing. Thank you so much for joining us, and we'll see you again next Tuesday at 10 a.m.